So it gives me great pleasure to talk about blisters and beyond in type 2 immunity. BP, Bullous Pemphigoid, has a heterogeneous presentation which makes the visual identification somewhat difficult. And you can see all the different ways that it can present here. You can see blisters, you can see eczematous areas, you can see urticaria. And so this is really, I think, one of our problems in BP and why patients can take 6 months or longer to get a diagnosis. So what would you do to further diagnose these patients? Something to think about. And we'll review some of that. So the non-bullous presentation on the left, you can see it causes an intense itch, sometimes with or even without anything, just itching in an older person. You really do need to think about bullous pemphigoid. And the lesions can range from urticarial to eczematous, they may remain non-bullous indefinitely or be in atypical variants and may never get a blister. So that's one of the things to really think about. And then on the right-hand side, you see what we, I think, typically think about with bullous pemphigoid, which is the bullous phase. And it's intensely itchy bullous eruption. And the blisters usually arise from apparently normal, or it can be from erythematous urticarial-looking skin, or eczematous-looking skin. And blisters may present at various stages of progression and exhibit painful erosions, crusting, weeping, and bleeding. And the erythema may not be visible in skin of color, so that's another thing that one has to kind of adapt to thinking about what this looks like in darker skin, and may not be preceded by a distinct non-bullous prodrome. So the annual global incidence is up to 76.3 cases per million, varying by region, and the prevalence estimates range from 0.13 to 1.13%. And both appear to be increasing in terms of bullous pemphigoid. And then in age, the majority of cases occur in older patients, often over the age of 60. And the incidence and prevalence increases about twofold for each successive 10-year age group after age 60. And the gender is about, there's a lot of variation here, but it's not that conclusive whether this is more male or female predominant, which probably means it's not one or the other. So BP, and in terms of treatment, it contributes to significant burden. And one of them is just the physical burden of the physical discomfort, the itch, the weeping, and the pain, I think are really a huge problem for patients. Sleep disturbance, fatigue, physical limitations, and dyspigmentation in skin of color. And there's just lots of reasons why these patients are fairly miserable. Socioeconomic burden, the families really have a huge burden. These patients are older, they can't really get to the doctor, they really have to have family often with them. There's a lot of healthcare costs from home visits, lab monitoring treatments, and increased rates of hospitalizations and longer hospital stays because of the age and comorbidities. There's a treatment burden with frequent laboratory monitoring, safety concerns related to the use of steroids and broadly immunosuppressive drugs, and feasibility issues with daily therapy administration. And then lastly, the mental health burden. These patients have impaired quality of life. They're depressed often, they're lonely, embarrassed related to the appearance of lesions, and anxiety about relapse. And that doesn't even get to the dementia that can be a component of this disease as well. So again, mental health is huge. Now, bullous pemphigoid is associated with increased mortality risk. And you can see the difference in the curves here. And it's a Kaplan-Meier curve of the BP cohort. And you can see that there's a greater than threefold excess mortality seen in age-matched, relative to the age-matched general population. And you can see the curve at the bottom, the blue curve there, is really much lower than the age-matched controls. So the major predictive factors for this, again, are the older age at onset. Here you can see greater than 78 years. Low Karnofsky score is not uncommon. Multimorbidity, especially cardiovascular disease, strokes, diabetes. High serum anti-BP 180 IgG is another predictive factor of problems. Hypoalbuminemia, high SED rate, high dosage of systemic steroids or no steroid-sparing treatment. And skin or systemic infections are not uncommon. And neurologic disease and dementia. So clearly these patients are really struggling with the approaches that we're taking. Timely diagnosis and optimal management are pivotal to minimizing BP-associated complications And patients with BP are more than twice as likely to develop serious infections as controls. As you can see on the left there, 40% versus 15.1. And also many patients with BP die due to infection. And it's really rather interesting to look at some of the studies in terms of the really high, even one-year mortality rates for these patients. The deaths are often due to infection, and systemic steroids are a strong risk factor, doubling the risk of serious infection. So early diagnosis and treatment are really critical to minimize the risks and improve long-term outcomes in patients with BP. And there's increased symptom severity if one waits, with larger, more painful blisters and higher risk of widespread skin involvement. There's a risk of infection through open blisters and erosions, and that certainly leads to systemic complications, especially if these patients are immunocompromised. There's a risk for more frequent hospitalizations. Persistent prolonged symptoms reduce their overall quality of life. And long-term steroid use leads to many problems, including osteoporosis if they're on it long enough, myopathy, hypertension, diabetes, and so on. And there can be up to a 2-year delay from symptoms onset to diagnosis. So the diagnosis is based on a comprehensive assessment, first with clinical assessment, talking about the medical history, patient-reported symptoms, and physical examination. As you can see on the left bottom there, that's really important. But also to even think about it, just if somebody's had a lot of itching and nothing else, to really think that this in an older person could be an issue. A skin biopsy should really be taken for diagnosis, both for histopathology and for direct immunofluorescence. DIF is actually looking for antibodies in the tissue itself. It doesn't require a serum. You just look in the tissue. You see on the DIF there, IgG linear complement deposited at the dermal-epidermal junction. On histopath, you'll see EOs and a subepidermal blister. And the serum sample will look for antibodies in this blood by ELISA, and also by indirect immunofluorescence. One can take the serum and put it onto skin and see where it binds. And so these are the kinds of tests that are done and really should be routinely done in patients, not just to do a biopsy or to make a clinical diagnosis, but to really confirm it with these additional tests. So we're going to play a video here about the mechanism of disease.
Bullous pemphigoid, or BP, is a chronic relapsing autoimmune skin disease characterized by itch, inflammatory lesions, and blister formation. In healthy skin, keratinocyte attachment to the dermal-epidermal junction is maintained by specialized hemidesmosomal proteins, including BP180 and BP230. Patients with BP lose immune tolerance and develop autoantibodies to these proteins. Consequently, antigen-presenting cells process and display peptides of BP180 and BP230 to naive T cells in the lymph node, which subsequently stimulates autoreactive T cell proliferation. Activated T cells differentiate primarily into Th2 cells, driven by cytokines such as IL-4, and are the main pathogenic subset. Th17 and Th1 cells are also involved in this process. Th2 cells produce type 2 inflammatory cytokines, such as IL-4 and IL-13. IL-4 and IL-13 stimulate B cell proliferation, autoantibody production, and class switching to IgE. IgG and IgE autoantibodies targeting BP180 and BP230 are produced, which, upon binding, trigger inflammation through both complement-dependent and complement-independent pathways and the internalization of BP180. Independent from complement, IgG4 and IgE autoantibodies cause keratinocytes to release inflammatory cytokines. The binding of autoantibodies, particularly IgG1, to BP180 and BP230 initiates the complement cascade, which leads to the recruitment and activation of various inflammatory cells. IL-4 and IL-13 not only mediate tissue inflammation, but also, along with IL-31, intense pruritus, a hallmark symptom of BP. This results in sensitization and stimulation of sensory neurons. The interplay between autoimmunity and predominantly type 2 inflammation, along with proteolytic enzymes, results in the development of subepidermal blisters in bullous pemphigoid.
So I think we're hearing a lot of common themes here in terms of the Th2 cells, IL-4, IL-13. And we know that there are biomarkers of type 2 inflammation that are increased in bullous pemphigoid. For instance, CCL17, which is a type 2 cytokine that attracts Th2 cells into the skin, is significantly upregulated in the serum of patients with bullous pemphigoid. Total IgE, NC16A specific IgG and IgE, and circulating eosinophils are elevated in the serum of patients with bullous pemphigoid. And it reminds me a little bit of what we heard about with urticaria, that there's IgE and IgG that are involved here. So eosinophilic infiltrates are found in the superficial dermis and inside blisters, as you can see on the right. So in summary then, chronic relapsing autoimmune skin disease is characterized by intense itch, inflammatory lesions, and blister formation. There's a heterogeneous presentation that requires careful differential diagnosis to prevent treatment delays. Patients experience significant burden, including increased mortality, functional limitations, and decreased quality of life. And autoimmunity and type 2 inflammation play critical roles in the pathophysiology of bullous pemphigoid.